Assalamualaikum warahmatullahi wabarakatuh. We are from Group 6. We'll be presenting case study of exercise ECG stress testing. Here is the content that we will provide in our presentation. Firstly, introduction overview of case study which will be presenting by Asma. Next, analyze findings case study which will be presented by Salina. Furthermore, potential response or arrhythmias during exercise presenting by Raja. Besides that, procedure and interpretation of case study will be presenting by Yashini. Last but not least, finding of case study presenting by Michelle, and lastly, SWOT and conclusion will be presented by me.
Good day everyone. Today I'll be giving a quick overview of exercise stress testing, and then I will present an interesting case involve a rare but a serious finding during this test in a sedentary patients. What is exercise stress testing? Exercise stress testing is a non-invasive procedure used to evaluate how the heart responds to physical stress, typical by walking on a treadmill. It helps detect an issue like coronary artery heart disease, arrhythmias, or other heart conditions that may not be noticeable at rest. During the test, we monitor the patient's heart rate, blood pressure, and ECG as the intensity of exercise gradually increases. It's a helpful tool for diagnosing chest pain, assessing exercise tolerance, and guiding treatment decisions. So the key observation and risk is we look for the ECG changes, especially ST-segment deviations, which may indicate reduced blood flow to the heart. While the test is generally safe, complications like irregular heart rhythms or very rarely a heart attack can occur, particularly in high risk of or sedentary individuals. In a published case, a 41 years old sedentary may underwent a treadmill stress test for shortness of breath. Although asymptomatic during the test, his ECG showed dangerous ST-segment elevations in the precordial leads, indicating a serious heart issues. So, further testing was revealed a critical blockage in the left anterior descending artery. He underwent emergency stenting and recovered well. To conclude, this case highlights the importance of evaluating a patient's physical activity level before stress testing. Sedentary individuals may be at higher risk of sudden cardiac events during the test, and protocols may need to be adjusted accordingly. Thank you.
Assalamualaikum, I'm Salina Jasmine, and I will be explaining this slide, which is the analyze the findings from the case report. So as you can see, this is the normal ECG paper, where this is took before the exercise, which is known as baseline ECG. So from here you can see there is no evidence of ischemia, and the sinus rhythm is normal, and there are no ST abnormalities found. And other than that, you can tell this highlights why stress testing is important for you to compare the before and after, because it can detect any other abnormalities. There are two ECGs here. The first one is the ECG during the exercise, and the other one is during the recovery phase. So during the exercise, there are few abnormalities found, which is we can find ST elevations found in lead V1 until V5, where it suggests acute transmural ischemia, usually associated with LAD deterioratory. Other than that, we can find also abnormalities such as reciprocal ST depression in inferior leads 2, lead 3, and AVF. So this will strengthen the likelihood of a significant of ischemic event. So despite having the ECG changes, but the patient had no chest pain. This is called as silent ischemia, often missed without ECG monitoring. So there is an immediate cessation of test was critical to avoid a catastrophic event. While during the recovery phase, we have the continuous reciprocal changes, and also ST elevation persisted in V1 until V3. So following the diagnostic findings, the patient was pushed to the cath lab, and the angiography showed the critical blockage in the proximal LAD, which is a major artery supplying blood to the heart. So the patient underwent angioplasty and stenting as well, and the procedure was successful with no leftover narrowing.
Assalamualaikum warahmatullahi wabarakatuh. My name is Raja Muhammad Kemagimi and I'll be presenting on the potential ischemic response or arrhythmias during excitation. So the first ECG changes indicating a potential ischemic were during excitation, where there are ST-segment elevation in precordial leads V1 until V5. As you can see in the second ECG, it can be observed during exercise at Bruce stage 4 with 3 to 4 mm elevation. This is unusual and concerning. This is because in a patient without prior myocardial infarction, it was concerning and can be suggested for a transmural ischemic process or possibly an acute coronary event like plaque rupture or vasospasm. The second potential ischemic response or arrhythmias during excitation ECG changes is we can see that in lead 2, 3 and AVF, which is not presented in the slide, but there is reciprocal ST-segment depression, and it was about 3 mm depression noted simultaneously with the precordial ST elevation. Reciprocal changes typically reinforce the suspicion of significant ischemic process, but there are no ECG to be presented. And the last one is persistence of ST elevation in early recovery. Continued ST elevation in V1 until V3 with reciprocal depression after stopping the test. The persistent changes during recovery increase the suspicions for true ischemic event as opposed to artifact or benign variants. So the key for ECG indicators of potential ischemic or arrhythmia during session in this context were first ST elevation in V1 to V5, and then reciprocal ST depression in inferior leg, which is 2, 3 and AVF, especially when they appear during peak exertion and continue into recovery. That's all from me. Thank you.
Procedure of stress test, as well as the interpretation of the case study. So first of all, under the procedure, we have identifying the patient correctly, where we have to ask for their full name and also the hospital ID. Next, the patient have been explained by the CVT about the test and also sign the consent letter. And moreover, we have to record the baseline ECG, BP and also vital sign before we start the treadmill. The patient will walk on the treadmill, commonly using the Bruce protocol, and before starting to walk, let them pre-test for 1 minute in order for them to get used to the treadmill. Then the speed and also incline will increase every 3 minutes, and the BP will be taken in every stages. So then we will be pressing exercise to start the test. Next, ECG and symptoms have to be continuously monitored, and the tests have to be stopped when the target rate is achieved or the patient becomes symptomatic, like the patient have chest pain or any leg pain or any other problems. Next, we have significant ECG changes occur, where the patient don't have any symptoms, but then the ECG can have changes. So we have to continuously monitor the ECG. So after reaching the maximum stage or reaching the target heart rate, we have to press recovery for 1 minute, and then we have to stop the treadmill in order to prevent the patient from falling down. Lastly, during the recovery phase, we have to follow and monitor the ECG and also the symptoms until the heart rate returns to the baseline. So next I'll be explaining about the interpretation of the case study. So for this case study, we have a 40 years old sedentary male with the exertion of the dyspnea for 2 months. And there's no prior cardiovascular risk factor with the baseline ECG and also echo is normal. So but when he is doing stress test, around in stage 4, at 10 minutes, there is ST elevation in lead V1 to V5 around 3 to 4 mm, and also reciprocal ST depression in lead 2, 3 AVF around 3 mm. So it is actually asymptomatic during and also after the test. So there's no symptoms present in the patient, but then there's changes in ECG only. So how do we manage that and how do we overcome that? So we actually stop the test immediately, and also we have given a medication like aspirin and also heparin and many more in order to calm them, in order to bring back their ECG reading, and also transfer them to the cath lab in order to see what are the other possibilities. And they also actually found that there is proximal LAD stenosis found, and angioplasty and also stent placement successfully with no residue stenosis. So then after the procedure, we check back again the ECG. It is actually normal, and the patient have been discharged after 2 days, and also he have been coming for the checkup for 2 years, and there's no any symptoms present.
I will present the finding of the case study. So the patient is 41 years old man who live a sedentary lifestyle, meaning he doesn't engage in regular physical activity. For the past 2 months, he complained of shortness of breath. In other words, he felt breathless when doing physical activities like climbing stairs or walking. However, he did not have chest pain or any medical condition such as high blood pressure, diabetes, or high cholesterol. And his family history was also unremarkable. Before any stress test was done, doctor performed a physical exam and ECG or at rest and echocardiogram. All of these tests were normal. The ECG showed normal sinus rhythm, and the echocardiogram confirmed that his heart pumping function was also normal with no structure problem or wall motion abnormalities. The patient then underwent a treadmill exercise test using a PRUSE protocol. This is a standard test used to assess how the heart responds to physical stress. At the 10 minutes of the test, something unexpected happened. His ECG showed significant ST-segment elevation in lead V1 to V5. These are the precordial lead, which focus on the front part of the heart. This type of ST elevation often suggests acute injury or poor blood flow to the heart muscle, especially in the area supplied by the left anterior descending artery. At the same time, the ECG also show replicas ST depression in lead 2, 3, and FF. These are the inferior lead. Replical changes further support the possibility of serious ischemic or reduced oxygen supply to the heart. The patient still did not respond any chest pain during or after the test. Due to these concerning ECG changes, the medical team immediately start treatment or prevent a possible heart attack. Despite all of this, the ST segment elevation only improved slightly and did not completely go away. This raised a suspicion of a fixed blockage in the coronary artery, never then just a temporary. To confirm the cause, doctor performed a coronary angiography. This is a procedure that uses type and X-ray imaging to look inside the heart blood vessel. The test revealed a significant narrowing in the proximal part of the left anterior descending artery, also known as the LAD. This artery is very important because it supplies a large portion of the heart muscle. Blockage here can lead to a serious heart attack if not treated quickly. The patient was then treated with angioplasty and stent placement to open the blocked artery. After the procedure, his ECG normalized and he was discharged from the hospital after just 2 days. At his follow-up, even 2 years later, he remained healthy and symptom-free. This showed that early detection and proper intervention save him from a possible heart attack or worse. In summary, although the patient had no chest pain, the exercise test revealed serious ECG changes indicating a dangerous coronary blockage. This case highlights the importance of monitoring ECG during stress testing even in asymptomatic patients, especially those with low physical activities level. Thank you.
Assalamualaikum, and I'm Nurnali Farzana will be presenting about SWOT and conclusion. The case report highlights the strength of treadmill exercise testing as a widely available and cost-effective non-invasive tool for evaluating coronary artery disease. It underscores the usefulness of treadmill testing in detecting silent coronary disease. However, its weakness is because of it is single case study, which caused the findings are not generalizable and limited discussion of comparative data or literature on similar presentations. A key opportunity is to tailor exercise testing protocols using physical activity questionnaires to estimate a patient's capacity more accurately. The threat arises from the possibility of exercise-induced coronary events in asymptomatic patients, as demonstrated by the 41-year-old man who developed significant precordial ST-segment elevation without symptoms, leading to the discovery of a critical LAD lesion. In conclusion, this case report illustrates that treadmill exercise testing, while useful, must be carefully considered in sedentary patients due to risk of triggering silent but severe coronary events, reinforcing the need for individualized assessment protocols before testing. Thank you.